Hi, we're here today with Dr. Thomas Reid. He is the medical director for Memorial Regional Cancer Center. Thanks for joining us, Dr. Reid.
Oh, my pleasure. Absolutely.
So, the pandemic has obviously meant significant changes, if not a total transformation, in the way healthcare providers are caring for patients. And this includes cancer care providers and patients. So, what can you tell me in terms of how cancer care has changed since coronavirus?
We want to make sure that our patients are safe. And we also want to make sure that the clinicians, the physicians and the nurses and support staff are safe so they can provide the adequate care to our cancer patients. So what has changed? Number one is any patient who comes to the hospital for a clinic visit is screened. They are screened for symptoms and their temperature is taken. And once they've cleared that hurdle, then it's okay for them to visit the clinic or the pre-op suite that they're supposed to go to. In the clinic, what we do to limit the number of cases within the hospital, as all clinics are doing, we encourage patients when they do come to the clinic that if they cough, that they use standard precautions, that they cough or sneeze within their elbow, they wash their hands as often as possible, they wear a mask, and if they have a chronic conditions such as heart disease, lung disease, diabetes, that they follow taking their medications. Because if they don't, that puts them at higher risk, including people who have chronic kidney disease or on hemodialysis and a number of other cardiomyopathies and a number of other diseases. And so how this has changed is who has access to the clinic. We now see patients who need to be seen urgently or new consults. All the others who are under surveillance, for example, they finish their treatment, typically we would see them in clinic to make sure they're doing okay. What we do now is through telehealth, just like we're doing now, is video conferencing with the patient. And we would see them in clinic if they had some complication related to therapy or some new sign or symptom that we had to address. The other thing that we're putting off is there's somebody who's under surveillance for their cancer. For example, they have had lung cancer. We would typically get, say, a CT scan 6 months after they finish therapy. Well, we're putting that off right now to limit their exposure to other people, not necessarily in the hospital, but through traveling, and also decreases the risk of our care providers so that they're not exposed to somebody who may have COVID-19. Because as you know, not everybody with COVID-19 has symptoms. The signs and symptoms that we ask people to present and get tested for is only a small fraction of people who have COVID-19. The true number, we're not going to know until everybody has the antibody test. And we get a sense throughout the nation, what was the true incidence of COVID-19 versus what was the incidence of symptoms and then, of course, mortality. So telehealth has been a big change. The other thing that is that sometimes therapies are being delayed, but not inappropriately. For example, if someone has a breast cancer who we're giving chemotherapy to before surgery, which is the normal part of their regimen. That's the way it was designed for them. Typically, we would do surgery within 3 to 4 weeks. It's acceptable to wait out to 8 weeks, and that's exactly what we're doing until this COVID-19 pandemic eases a bit and we have adequate resources to do all of the surgeries. Now, there's the White House CDC guidelines, the American Society for Clinical Oncology, and Center for Medicare and Medicaid Services all have guidelines in terms of when we should resume ramping up. For example, when can we start doing elective surgeries again? Or when can we, or other minor breast surgeries, for example, very, very early stage breast cancer. Other things that chemotherapy has been on hold in addition to surgery, again, not inappropriate, delayed, but it's also made us think about when should we continue chemotherapy. It's very well known in the oncology circles that if somebody has advanced disease, a metastatic disease, that if they've had 3 cycles of three different regimens of chemotherapy, anything beyond that doesn't add much more than a few weeks of life, and at great cost, and possibly to the patient, but also to the health industry. So it's made us think more about when we should stop treatment. The other thing is that some people are, say, in the setting of, say, colon cancer, that instead of giving 12 cycles of chemotherapy, they're only giving 6, with the idea is that we're trying to reduce the likelihood of the patient becoming immunocompromised with the chemotherapy. Whether is 6 cycles okay compared to 12 cycles, the standard is 12 cycles. We don't really know, but there's the issue of what's the risk benefit ratio. Yeah, 12 cycles is the standard, but if we do 12 cycles, we may have more patients who are immunocompromised and increase the incidence of COVID-19. It's theoretical, but we're trying to put the patient. We're trying to consider the patient.
Of course. You
Yeah.
know, one question in a lot of people's minds might be, I need to schedule my mammogram. I'm up for, or my doctor has prescribed a colonoscopy because I'm of that age. Should people be scheduling these, or
Yes.
should they be waiting until, shall I say, all this passes?
Right, good question. We want to add on to that low dose CT scanning for lung cancer screening. We in oncology are postponing the screening exams for mammograms, colonoscopies, and low dose CT screens. There's no adverse outcome to doing that. And it puts the patient at increased risk for exposure to COVID-19 compared to waiting a couple of months to get their screening. And it's really only a couple of months. But this is not to say if somebody has symptoms. For example, if they had a screening mammogram a year ago and they've been fine, and they're due, say, in May, and it's being postponed until, say, July, and all of a sudden in June they feel a lump, well, they don't wait till July. They come in and talk to their primary care physician and say, look, I've got this symptom. Same thing for colonoscopies. If they have bleeding, rectal bleeding, or they have dark stools, or if somebody has known lung disease, they call their physician and say, look, I've got this new cough I didn't have before and blood's coming up with it. Again, those don't wait for the screening. That's no longer screening because they're now symptomatic. They have to have diagnostic imaging.
Okay, so switching over to cancer patients, should they postpone treatment because of COVID-19 or not?
Yeah, that's a really good question. Most treatments do not have to be postponed. If in fact they have COVID-19, and there are patients who do have COVID-19, we do defer those treatments, because most of the treatments, except for endocrine treatments for the most part, most of the treatments we provide, and sometimes the underlying illnesses the patients have, do put them at risk for being immunocompromised. And so there are certain cancers that we certainly treat right away, because the cancers themselves are life-threatening in the short term. And these would be, say, acute leukemias, and these would be high-grade lymphomas. And other chemotherapies can be put off for a while, say sometimes 3 or 4 weeks, but we wouldn't want to wait a lot longer than that. So in the setting of COVID-19, just because we're in the pandemic, we don't not give chemotherapy. We have to do the risk benefit for each patient.
Okay, and for
And
cancer
let's suppose
patients,
somebody,
oh, go ahead, I'm sorry.
sorry. So if somebody is COVID-19, for example, there are situations where somebody develops COVID-19, we would let their immune system manage their COVID-19, and hopefully they'll develop antibodies, and we can resume therapy after they've been tested negative for the COVID-19.
So for cancer patients that are undergoing treatment, what precautions can they take themselves to reduce any risk of COVID-19, or even just to, ease their fears?
Sure, absolutely. Well, the overall risk of getting COVID-19 is, we're going to find out, I think, is going to be very low. Or the fact that you may have already been exposed to it and you don't know, you've never developed the symptoms. And here's the other thing, is that most of the time, the symptoms of COVID-19 are no different than the flu. It can be, say, joint aches, muscle aches, even diarrhea, headaches. These are things that we don't really think about when we talk about COVID-19, but those are more common than the shortness of breath, the cough, and the fevers. Those are people who have more extreme diseases, and they have to be attended to right away. But you can have these minor symptoms as well. Other symptoms you could have is a nasal drainage, like a runny nose, a sore throat, or a change in taste or smell that's brand new. All those things can happen. And so what they can do is, number one, if they have an underlying disease that puts them at increased risk, say lung disease, diabetes, heart disease, on dialysis, take your medicines, optimize your medical management. That's number one. Number two is do all the things everybody else is supposed to be doing. That is, cover your coughs and your sneezes with your elbow, wash your hands frequently, social distance 6 feet, avoid crowds. If you know somebody's sneezing in a crowd, get away from them. Stay home unless you absolutely have to go out to get groceries. And if you can, have somebody else go out for you. If you're sick, stay home, because when you're sick, your immune system can be, you can be immunocompromised, and then you're at increased risk for COVID-19. Who else is at risk? Well, anybody over or at the age of 65 or older. So those folks are at risk, but and of course, if you're over 85, it's even higher. As we get older, our immune systems just aren't as good. So any of those risk groups and over the age of 65, be especially careful. Take the standard precautions and take the medicines if you have any of those comorbidities.
Dr. Reid, thank you very much. Appreciate your time and your valuable insights, and thanks for all you do for Beacon.
Oh, thank you so much. I appreciate it.